Hi, everyone. Welcome to the Clinical Care Options Neuroscience Podcast. I'm your host, Gabby Giaccona. On today's episode, I'll be speaking with Dr. Anita Clayton about glutamatergic and GABAergic agents that are approved and being researched for use in major depressive disorder. This episode is part of a larger educational program entitled Modulators of Glutamate and GABA for MDD. For more information on the program, including a downloadable slide set and clinical commentaries, as well as more information about Dr. Clayton, please visit the show notes for this episode. Now, let's get started and hear about these exciting developments in MDD treatment. Hi, Dr. Clayton. Thank you so much for being here today. Let's start off with a quick basic question. Can you explain to us what GABA is and why it's being targeted in major depressive disorder?
So GABA is the primary inhibitory neurotransmitter in the brain. The GABA-A receptor is a transmembrane ligand-gated chloride ion channel, which mediates fast inhibitory synaptic signals through rapid postsynaptic membrane hyperpolarization and slow persistent extrasynaptic signals, where neuroactive steroids and positive allosteric modulators keep the ion channel open. Whereas the transmembrane metabotropic GABA-B receptor produces slow and prolonged inhibitory signals via G protein-coupled receptors. Today, I will focus on the GABA-A receptor. All 19 of the types of GABA-A receptors are made of 5 subunits that transverse the membrane and form that ion channel. Those subunits usually are made up of 2 alpha, 2 beta, and 1 of either gamma or delta. A balance is maintained by the GABA inhibitory actions versus excitatory glutamatergic systems. Disruption of this balance may lead to major depressive disorder.
Okay, and this is moving us away from that monoaminergic hypothesis of depression, correct?
Yes. While the monoamine hypothesis seems to work, we also know that lots of other factors can cause or contribute to the specific phenotype of depression. I really mean it. This is so exciting to me. It's what I was thinking was going to happen when I was early in my career. And no, it's happening now at the end of my career, but so many other mechanisms are also being looked at.
That makes sense. We need more options for more presentations and for more people to really hit full remission. But I'm curious, there are so many medications that target GABA already. Why aren't they being used in MDD?
So at least 5 types of molecules bind to the GABA-A receptor. Alcohol is an indirect agonist and binds to extrasynaptic GABA receptors, while benzodiazepines bind only to fast, basic, that means short-acting, synaptic receptors. These do not have antidepressant effects. Anesthetics, GABA, and neuroactive steroids like allopregnanolone bind both to synaptic or fast but short-lived receptors and extrasynaptic receptors, which have a tonic or prolonged effect. And, certain drugs are still with the same mechanism haven't worked. So there's been 2 studied related to GABA-A neuroactive steroid positive allosteric modulators that did not separate from placebo in their populations. So there's subtleties about these drugs. Where do they bind? How tightly do they bind? Do they bind to that GABA-B receptor too? What kinds of things are going on?
Then what is it that leads to the different indications with these molecules? Like brexanolone is approved for postpartum depression, but not yet for major depression.
Brexanolone was not really studied in major depressive disorder. It is an allopregnanolone analog, as is zuranolone. But in fact, thinking about neuroactive steroids like allopregnanolone and those that have a positive allosteric modulation effect suggested that postpartum women would be more likely to respond to allopregnanolone analog because they're actually experiencing a significant drop in progesterone, allopregnanolone, estrogen in the first 3 days after delivery, and may be hypersensitized to this change either during pregnancy or postpartum. And these positive allosteric modulators, as I mentioned, bind to synaptic or fast GABA-A receptors and extrasynaptic GABA-A receptors that have sustained effects. Non-pregnant women, though, and men also have neuroactive steroids as well, which is why zuranolone, an oral GABA-A neuroactive steroid positive allosteric modulator, has been studied in women and men with MDD. Think of postpartum depression as a major depressive episode occurring at a specific time or during a specific period in a woman's life. It's still a major depression, and zuranolone was subsequently then studied in postpartum depression and in major depression.
Great. And then jumping into zuranolone, we're recording this podcast at the end of June 2023, and it's my understanding that a decision is expected by the FDA in early August on zuranolone for use in both postpartum and major depression. And I know that you were involved in some of the clinical research. So what are some key points that you'd like to tell our audience?
Availability of zuranolone would represent a true paradigm shift. Zuranolone is administered as a short course, one dose per day of 30 milligrams or 50 milligrams orally, given at night for 14 days. It has a rapid response. Zuranolone separated from placebo after only 2 doses, and at the primary endpoint at the completion of the course of treatment, so on day 15. It was well tolerated during the 14-day course. And because it's a short course, it doesn't have long-term adverse effects that we see with chronic use of standard of care antidepressants. And in a maintenance of effect study, the therapeutic benefit is sustained in open label responders for a full year without further intervention in 45 to 50% of the patients, depending on dose, with 75 to 80% requiring either just the one course or a second course of retreatment. This is an amazing shift, and we really have to think about how we would apply this in our patients, because it's just different than giving the monoamine reuptake inhibitors that we've had for a long time.
Okay, so what is that period of time in between doses that people might expect if they're not having a response to the first 14-day cycle?
So remember, zuranolone, like brexanolone, acts as a neuroactive steroid positive allosteric modulator at the GABA-A receptor. That means it works fast through binding to synaptic GABA-A receptors, and that effect is sustained through binding to extrasynaptic GABA-A receptors. Patients in the long-acting maintenance of effect study did not take zuranolone every day over the course of a year. They took the initial course of 14 days, and if they were responders, then they were followed every 2 weeks with a PHQ-9, and if they started to show relapse, then they came in for a clinic appointment, and the HAM-D17 was completed and other scales. If they had relapsed, and it had been longer than 56 days since their original 14-day course, then they could receive an additional course of 14 days of treatment. What was seen was that in a year, about 50% of initial responders to the 50 milligram dose only needed that treatment. They never needed another retreatment or other interventions in 12 months. And only one repeat course was needed in 12 months of follow-up for an additional 25% of initial responders. In addition, functional impairment also improved rapidly so that people were able to get back to work, relationships improved, they were able to think, sleep, and function, have energy, those kinds of things. So in general, a much smaller percentage, about 25%, needed either 3 courses, 4 courses, or 5 courses over a 12-month period. And those had to be separated by these 56 days.
Okay, with that, I am anticipating that as patients start to hear about this, they're going to say, hey, I would like to be on this 14-day, once a year, twice a year treatment versus my everyday antidepressant. Is that something that would be feasible?
So remember, Zuranolone was studied in major depressive disorder, not treatment-resistant disorder. So these are not people who would necessarily need to go through several courses of treatment for an adequate time period with an adequate dose before being found to not be responsive to treatments. Insurance companies are going to want to require one standard of care generic medication as a first-line treatment. But as you suggested, given this profile, patients are going to demand it. I mean, what person with major depression doesn't want to get better quickly and only have to take medication for a 14-day course of therapy? So they're not going to need to take medication chronically or indefinitely. I will say that some patients were treated with monotherapy with zuranolone, and some patients it was added to a stable dose of a standard of care antidepressant, and there was no difference in their outcome. The only difference was that those people who had to continue on their standard of care antidepressant experienced those long-term side effects that we really want to avoid. Things like weight gain, cognitive impairment, sleep disturbance, sexual dysfunction, and continued functional impairment. So this could really, really change people's lives and quickly, and they could get back to work, they could get back to taking care of their family and those kinds of things. The key thing there too is that the functional impairment with major depression was significantly improved within 14 days from baseline, with progress to near population norms at 6 weeks from baseline. So that's also key. Suicidality did not increase with zuranolone, so all patients had a marked decrease in suicidal ideation, but that may have been in part due to frequent visits. There were actually 4 of them, counting the baseline visit in the first week of treatment. Someone who's actively suicidal might benefit from the rapid response, even if they potentially need to start as an inpatient to ensure their safety over the early days of treatment and a decline in their suicidal ideation. If they have intolerable adverse effects with standard of care antidepressants, but the medication worked for them, so it didn't lack efficacy, they still may not want to continue to take those medicines. They may want to very well switch so that they don't have emotional blunting, weight gain, sexual dysfunction, cognitive dysfunction. So in those patients as well, zuranolone might be a preferred option.
And can you just clarify one thing for me? This is an oral medication, but does a healthcare professional have to administer the medication, or do patients have to be observed for any period of time while taking it? Or is this fully at home? A patient can do this independently?
Yes, the initial studies started people inpatient for a week and then sent them home for the second week. But all of the phase 3 trials have patients taking the medication home, taking it on their own at home, and coming back in for frequent visits, as I mentioned. But still, the entire course is oral, once a day at night, and taken at home.
So before we move on to focus on glutamatergic agents, is there anything else that you'd like to share about GABAergic agents or the neurosteroids as they're being explored in MDD?
Yes, GABA-A neuroactive steroid positive allosteric modulators represent a true paradigm shift in the treatment of major depressive disorder. I have been waiting for this type of breakthrough my entire career in psychiatry. We've had monoamine oxidase inhibitors, and we've had monoamine reuptake inhibitors. So these are what we've had, and now this is something incredibly different and new. And we're likely to see more options with availability of drugs with other new mechanisms of action that are in development for major depressive disorder and or postpartum depression.
That's so great to hear. So now that we're moving on to glutamatergic agents, let's start off with the basics again. What is glutamate and why is it being targeted in MDD?
Glutamate is the most abundant excitatory neurotransmitter at several types of receptors in the central nervous system. NMDA, AMPA, and kainite receptors modulate fast excitatory neurotransmission, while at least 8 metabotropic receptors located pre, post, and extrasynaptically indirectly modulate ion channels via G-protein coupled receptors. Glutamate plays a major role in learning, memory, and mood. Like GABA, glutamate is implicated in the pathophysiology of major depressive disorder, including maintaining the balance of GABA-A versus glutamate activity.
With this balance, are we thinking that it is too much glutamate activity or too much GABA activity, vice versa?
So it's too much glutamate activity and or too little GABA activity. So GABA fails to inhibit the excitatory aspects of glutamate, and that causes neurotoxicity, actually.
So then we know that one of the key differences between traditional SSRIs and glutamatergic drugs, one of which is esketamine, is the time it takes to elicit an antidepressive effect. What is it about targeting glutamate that allows for this quicker response?
Remember, esketamine is an intranasal spray acting as an NMDA antagonist, a sigma-1 agonist, and at the norepinephrine and serotonin transporters. So targeting the fast excitatory neurotransmissions like at NMDA and AMPA receptors makes rapid action possible, including changes within minutes or a few days.
Is there any need for it to build up in a patient's system like we see with traditional antidepressants?
What I would say is esketamine does have a titration schedule, first twice a week, then upping the dose, and then moving to once a week, and then potentially stretching it out to 2 weeks or possibly more. So there is this titration schedule, but it isn't so much that the effect needs to be built up because the effect is very rapid.
So with that quick effect, is one esketamine session enough to determine if it will be effective for a patient?
I would say not necessarily, because we're adjusting the dose upward as well. So very often, if you're just using one of the sprays, we might see a benefit. We might see dissociative symptoms for a couple of hours afterwards, but I wouldn't rule it out. For one thing, it's prescribed for treatment-resistant depression, and I really want people to be aware of that. Because if you think about that, it's going to be harder to respond. So the fact that people respond is great if they haven't responded to other things, whereas they may, in fact, need to get those treatments frequently.
Yeah.
It's a trade-off there, perhaps. So we might see it work within hours after administration, but the determination of actual response and certainly remission takes up to 4 weeks.
Treatment-resistant depression is 2 or more failed medication trials?
When those medication trials have used an appropriate and adequate dose of the antidepressant for an appropriate time period, usually 6 to 8 weeks. One of the problems is that people aren't always getting an adequate dose. They may be started on a lower dose and have side effects, especially if they're anxious. Most people have more side effects because they're internally focused and they're just recognizing them, and then they get magnified. So they may have had that. They may be rapid metabolizers, meaning that even at a regular dose, they get rid of it from their body relatively quickly, and so the dose for them at steady state is inadequate. Or they may be very slow metabolizers, which means that even at normal doses or even at low doses, they might be having bad side effects because they have that drug hanging around for a long time.
And then another glutamatergic agent that we have is the bupropion dextromethorphan combination. How long should that agent be trialed for?
I just want to remind you that esketamine must be administered repeatedly, about every 2 weeks weekly, and dextromethorphan bupropion combination is taken orally twice daily chronically. So the oral 45 milligrams of dextromethorphan and 105 milligrams of bupropion combination, which allows for a non-dissociative dose of dextromethorphan to be used, acts at serotonin, norepinephrine, and dopamine transporters, and as a sigma-1 agonist and NMDA antagonist at ionotropic receptors. In clinical trials, significant improvement in depressive symptoms versus placebo was seen within the first week of twice daily treatment for MDD. And it continued to separate further with increasing improvements over time.
Thank you. And then regarding that combination agent, a lot of patients have probably tried bupropion in the past. If they were not responding to that, or if they experienced some intolerable side effects, is it likely that they'll have the same response with the combination, or should they give it a try?
So the bupropion dose of 105 milligrams in each dose, given twice daily, is still 210 milligrams, which is well below the lowest effective dose of bupropion, 300 milligrams per day. That is what allows for a lower dose of dextromethorphan. And so side effects are really minimized. The most common side effects of the combination treatment are similar to those we see in other antidepressants like dizziness, headache, diarrhea, drowsiness, dry mouth, and excessive sweating. So I think it's definitely worth a try.
All right. And then one question I know comes up a lot is, can you just prescribe bupropion to a patient and then ask them to pick up some cough medicine containing dextromethorphan and use that as their own combination at home?
I think the concern would be the abuse potential. I'm not sure that that's a great idea. In the clinical trials, one of the clinical trials of that combination was compared to bupropion alone at the 105 milligram dose twice daily also. And so it was really looking at what's the benefit of having dextromethorphan in that combination. It really was significantly better to have the combination than just bupropion alone.
So right now, ketamine is only available via a REMS program. It has to be administered under supervision of a healthcare professional, and patients are required to be monitored for at least 2 hours following administration. Do you see these requirements becoming more relaxed or changed in some other way in the future?
I doubt it, because the dissociative effects, the reason for the REMS, persist with repeated administrations. Now, they may become less prominent or they may not last quite as long, but they do persist. So with each repeated administration, you're going to see that. And so they're requiring the 2 hours where you can observe a patient through that dissociation. I've had patients who had no significant anxiety and then suddenly in one of their treatments developed major panic symptoms and required really a lot to calm them down. And so I think the REMS is there for a reason, and it's important. The other thing is that a recent study of 2,000 adults who were using at-home ketamine troches, which are dissolved sublingually over about 30 minutes, they found that 55% of adults and 58% of millennials exceeded the prescribed dose, while 26% they said they would rather use ketamine than antidepressants or anti-anxiety medications. This is a potential problem of ketamine misuse. And so prior to prescribing and across care, we really need to assess for substance use or misuse, and it must be addressed. This is just good clinical practice.
Right. And that leads nicely into my next question about abuse potential. So as you just mentioned, ketamine has abuse potential, and so does dextromethorphan. What kind of concerns should clinicians have in the context of depression treatment? Do you see patients who are seeking out these drugs more for the high than for depression treatment?
In my personal experience, and I was involved in the clinical trials of both agents, I've had patients that abused other controlled or illicit substances previously who were then tried on esketamine. Several of them ultimately had to be discontinued from the treatment due to substance misuse over the course of their esketamine treatment. Also recently, I saw 3 cases of young women who purportedly failed other treatments for major depressive disorder and were tried on dextromethorphan bupropion combination. But in their cases, it turned out that non-response to antidepressant treatments was actually due to chronic use of cannabis multiple times daily and other illicit substances. As I mentioned above, the drug abuse potential is a significant problem with these meds and impacting response to treatment. So prior to prescribing and across care, substance use and misuse must be assessed and addressed.
All right. Like you said, that should really be a standard of care there.
It should be a standard of care.
And then I'd just like to go back to talking about the dissociative state with esketamine and having potentially like anxiety and panic attacks afterwards. Is there a role for a psychotherapist or any kind of psychotherapy to assist ketamine therapy?
The studies didn't use psychotherapists. And in clinical trials, you try not to enhance the effect of a treatment of your behavior and being friendly or taking care of them or that kind of thing, because it will also enhance the placebo response. But I will say that when you are sitting there and spending 2 hours with someone, you may in fact be contributing to a benefit there. We don't know what would happen if psychotherapy was explicitly used with the treatment with esketamine.
Okay. Do you know if there are any ongoing trials of that?
Not that I know of. Certainly, we don't want to add an additional requirement like psychotherapy may be, for example, for psychedelics, if we don't have to. And the trials really showed that you just needed to be there to be following their responses and their various dissociative experiences.
So during that 2-hour waiting period, do patients typically bring a book or like their phone to watch TV? Are they allowed to?
No, they don't, because they often have experiences, and there's a whole scale for measuring this, but they have things like the parts of their body feel bigger than normal or smaller than normal. They feel like colors are brighter or duller, sounds are too loud, usually not too soft. They don't feel real. They feel like they're outside their body, things like that. We tend to keep the lights down and not have bright lights on them because that is bothersome in such a setting like that. I just don't think really people could get through that with reading or watching TV. I wouldn't want them to watch TV. That might be overstimulating.
Yeah, I guess that would depend if they're watching like an action movie or a Bob Ross video or something. Yeah. All right. Thank you for this discussion. I've learned a lot about GABAergic and glutamatergic drugs and their use in major depressive disorder. Before we close out the podcast, is there anything else you'd like to share about either of these agents?
So NMDA antagonists, like GABA agonists, have the potential for rapid action, but current products require a repeated or chronic treatment when getting at the glutamate system. Since the balance of activity at GABA and NMDA receptors is important, perhaps combination treatment may be studied in the future.
That'll be very exciting.
Well, thank you so much, Dr. Clayton. I've learned a lot from our discussion today, and I think our listeners will have a ton of information to take into their clinical practice. As a reminder to listeners, to learn more about the use of glutamatergic and GABAergic agents in major depressive disorder, you can view the full program, Modulators of Glutamate and GABA for MDD, by clicking on the link in the show notes. As always, thanks for listening.